Welcome to County Conversations. I'm Chris Coates. I'm the County Administrator for Cheshire County. This is a podcast that brings you county government, and so that you have an opportunity to have a little bit better understanding of what we do in the county. And over the last year or so, we've brought you probably close to 25 episodes, and we will continue to do that just to give you an opportunity to look into what magic comes out of the county government and how we care for those in our care, and then have conversations also on occasion about what we think are cool things happening in our county. So in the past we've had Monadnock Economic Development Corporation and the work they're doing, or Southwest Regional Planning Commission and the work they're doing, and we've also had the Greater Monadnock Collaborative come on, and we'll continue to do that throughout. But today we're talking about Medicaid. You know, Medicaid cuts, we've heard a lot about that. We've heard a lot about the reduced to access to health care for individuals, potentially leading to loss of coverage and making it hard for some to afford necessary services like medication or treatments. And what we wanted to talk about today, and I have Cheryl Trombley, who is the Director of Finance for Cheshire County, and Catherine Kindop, who is the Nursing Home Administrator up at Maplewood, here because I'm dangerous with the knowledge I have, but they actually know the knowledge a lot better than I. So we're going to talk a little bit of what it means to the county, and especially with the passing of the Big Beautiful Bill, if there are concerns out there, and just hopefully you'll walk away a little bit more educated about what's going on when it comes to Medicare or Medicaid. Good morning. Good morning.
Good morning.
Good morning.
All right, so talk to me how within the county we have Medicaid and Medicare being utilized to help fund programming, or individuals that are utilizing for their care services in there.
So if you're looking at a county global sense, we have multiple programs that Medicaid is supported by. Of course, our nursing home, which we'll talk about, there's the majority of our residents living at the facility are their payer of source is Medicaid. But we also have programs such as Connected Families that their programs are supported by Medicaid, and that program is one that takes care of children that are at higher needs that could end up in out-of-district placement. And so there is a component of that program, a great component of that program, that is covered by Medicaid. We also have a behavioral health court that the participants in the behavioral health court, the drug court, which is now called treatment court, that the clients, they're enrolled in the Medicaid expansion program, and that's probably one of the biggest areas that could have a concern of the requirements under the new Big Beautiful Bill that could cause for those clients to be either no longer eligible for the program because they don't meet the requirements, or which could then end up becoming a cost to the county to pay for the services that they need that are currently covered by Medicaid.
Is the majority of it, like if we took the nursing home, is the majority of individuals in our care Medicaid or Medicare?
Oh, by far and away Medicaid.
Yeah, I mean they're dual eligible to. So
what does that mean?
What that means is, even though they have Medicare, because Medicare is a federal program. Mm-hmm. Medicare is something that when you have a deduction out of your paycheck, which is called FICA, a portion of it goes in to support your Social Security benefit as you get older and retire. And then
I'm just curious, when can you take that?
You can take it currently at the age of 65. Mm-hmm. There's, I think to receive full benefits, maybe it's like 67. There's somewhere between the 65 and 67, but the Medicare component of it is 1.45% of your wages earned go to pay to support you through Medicare benefits. Mm-hmm. What Medicare benefits do is when you become 65, you are eligible for different components of Medicare. Medicare A is your hospital benefit. If you end up in the hospital, overnight, or in a nursing home needing skilled benefits, Medicare A pays for it, and it's a limited benefit because it only pays for so many days. Typically 100 days is what your coverage for that benefit is. Medicare B is something that you have to pay for, and Medicare B is something that you have to enroll in, because if you don't enroll in it, you end up getting penalized for every year that you don't enroll. That is like your physician's benefit. That's when you go to the doctors and you need services because you're not feeling well, because you're getting your annual physical, or it also is what supports our residents in our nursing home when they have those type of care that is needed, meaning therapies or having to go to the hospital. So our residents in being dual eligible is underlyingly, the majority of our residents are over the age of 65, so they have Medicare, but to pay for the long-term care portion of their stay, meaning that the nursing home, the overnight rate, which is, it's costly to be in a nursing home, that is covered by either Medicaid or that you have your own private funds and you pay the daily rate out of your pocket. So the majority of our residents do not have resources and assets to pay that daily rate, so Medicaid then becomes the payment to live in a nursing home.
Do all nursing homes take in Medicaid recipients?
Ooh, that's a loaded question. There are some that don't proceed down that path, but they're very few. But the majority of nursing homes, they do end up taking Medicaid recipients.
Okay.
But it's difficult because the payment is probably less than half of the actual daily care cost.
So if you have like a $600 daily rate, I'm not saying that's the number, but if that was the number, then you would say that it's less than 300 is what you're getting from Medicaid. Probably closer to
260, 270.
Yeah.
So
Yeah,
it's a significant reduction.
So that means the majority of people in your care are Medicaid. The daily rate is here, and you're getting from the government here, and we're also now talking about, and which we'll be getting to in a second, cuts across the board. And we can talk about EMS, we can talk about how Medicaid goes away at corrections facility after 30 days, and it's on that, so we'll get to those in a second, but let's talk a little bit more about what that means to the nursing home. Like, how do you make up that difference then? Is it that the taxpayers pick up that different cost?
Yeah, essentially, I don't want to do all the talking here, but essentially, yes, that's what ends up happening is the taxpayers subsidize the loss of the nursing home between the cost of care and the Medicaid daily rate. And New Hampshire, unfortunately, has one of the lowest Medicaid reimbursement rates in the entire country. Is there anyone lower than us?
We've vacillated between the bottom three for the last.
Yeah.
And what is it, when people say that, what does that mean? That the legislature sets the rate, so that money's that 260 is what they're setting? It could be actually higher. Is there examples of higher, numbers?
There are many states that are higher, but to oversimplify, I would say that the legislature sets the pot of money aside of what they're going to allow. And then from that, there's a manner in which each nursing home gets their Medicaid rate determined to make sure it's as fair across the board as possible. And that is based on the residents, the case mix. So somebody with higher acuity that takes more nursing hours, there's a scale that rates them. And so therefore it's trying to be fair so that the folks who have difficult, challenging residents, such as somebody on a ventilator, requires so much more care than somebody who is more physically capable. And so there's different rates. The rates are not set by the legislature, but the amount of money is set by the
So
legislature.
can I just because you said something about on a ventilator, but in this day and age, you can have that situation, but does it also qualify because I would think we're seeing more and more is dementia, Alzheimer's. Is that a higher rate pay too because of that, or is that just part of the day in and day out?
I would say by far and away it's part of the day in, day out. Now, at Maplewood, we have our own special unit. We call it TLC. We have that standing for Therapeutic Living Center. But through the state of New Hampshire, it's considered we're considered an atypical provider for those number of beds. There are 3 counties that offer atypical care, and the residents there could have dementia with expressing difficult behaviors. They could have psychiatric components. Specifically in the atypical unit, there is a slightly higher pay rate, and one of the things that we need to keep in mind is sometimes when we have troubles with our thinking and expressing ourselves in difficult ways, it's not going to show up in how much nursing care physically you need to give, such as eating, bathing, dressing. When it's more of a cognitive challenge, it's harder to put a dollar figure on the care costs, because you do need a higher number of staff to resident ratio for everybody's safety, but it's less about the physicality and more about how to approach residents, how to make sure we get them at their best. So when you talk about dementia separately, most residents in our long-term facility have troubles with memory. They don't necessarily all have dementia, but we'll just say lots of troubles with memory. They're usually in our general population, and so that case mix index I mentioned, it applies to them. So whether you have a lot of physical needs, maybe you've had a stroke and it's been a number of years, but you do need a lot of assistance, or you've got progressive memory loss, a dementia of some sort, those are all lumped together in how our rates are set.
Okay. All right.
And going along, the funding mechanism for Medicaid for long-term care is unique in New Hampshire. Medicaid is a state program, and as Catherine
With
indicated,
federal money.
It's run by the states, and it's part of whatever their plan is. So it's unique state by state. And in New Hampshire, what is even more unique about it is, even though it's a state program, they're the ones that set the overall budget as to what they're going to determine they're going to pay overall for residents living in nursing homes. What's unique about it is that 50% of the actual funding comes from county governments, and the other 50% comes from the federal government. So the state is the one that determines what the overall budget's going to be, but then they bill the counties each month to get the county share, that they then go and get the matching funds from the federal government. And when they combine those two amounts, that's what then gets divvied back out to the nursing homes based on their monthly billing. So that process is, even the state sets the amount, and then they then take the cost from all the nursing homes through a cost report program. And even though the costs are much higher than the money that they divvy out, what they have to do is then they apply what's called a budget neutrality factor, because even though it might cost, $600 a day on average to truly pay all the nursing homes for their care, they have to discount that to say, well, we understand it may cost you all $600 a day on average, but we only have $300 a day to give you. So they have to reduce the dollar to divvy out what they can then afford to pay the nursing homes. So that is what ends up discounting what all the nursing homes receive. The private nursing homes, when you ask, do all the nursing homes take Medicaid residents, as Catherine said, it's not necessarily all, but the majority of us do. The private nursing homes then have to kind of make a portfolio of the payer source of what they can afford to take in order to, because they have to be able to at least break even or hopefully make a profit. So they have to find a balance of what they can handle for residents between how many Medicaid, how many private pay, which you can't necessarily know how many private payers you're going to end up getting, but that's where they have to challenge more for skilled nursing residents, which those are the people that are getting their hospital Medicare A benefit to care for them, because that's where you get a higher reimbursement, because it's an intense 100 days of trying to get somebody better again to hopefully return to home. It may have been a fall, broken hip or something, where they're having to get something to get them back to their previous state. So we don't have to necessarily always challenge ourselves to be high on the skilled area. As much as we can provide that care, we do, and we do it well. But the privates are getting them in their doors quicker before we even have the ability to get them in, and we then have our taxpayers that help support our most vulnerable residents that need their care in a nursing home, to support the fact that our Medicaid rates are much lower than what our costs are.
So, plans.
Right now is the open benefit choice for Medicare, and I understand that some of the plans are no longer available in our state, so I don't have any updated information from our social services to know the direct impact on our residents.
Yeah, I've actually been approached by 2 state reps that have real concerns, because all of a sudden it's just like, it's like a little crazy in Concord right now, because they didn't know that they weren't aware of this or whatever that story is. I'm waiting for the email to give me the bigger story, but it is concerning. What does that mean, that people have the opportunity then to sign up for a plan and then one of the ABCDs?
So every year this time, it's what's called open enrollment, which is, what we're all kind of familiar with even our employer things, but it gives you a period of time to make an opportunity to change plans from whatever you've been enrolled in all year long. There is obviously your traditional Medicare, which again we pay for out of our paychecks every week. But there's also, over the years, and it's been many years, what are called Medicare Advantage plans. It is not the traditional, but it is a choice. It's a choice for somebody to either to stick with the traditional or to go with these Medicare Advantage plans. The Medicare Advantage plans get, interesting to people, especially living at home, because they may have some extra bells and whistles of, maybe some dental options, maybe some vision options, some things that help, people that are in good health, living at home in their elderly life, to have some extra bells and whistles. Those extra bells and whistles are not anything are necessarily needed in a nursing home, because the daily rate that you pay for in a nursing home, whether you're getting private pay, you're paying private pay, or if you are Medicaid, it's all inclusive. And what's happening right now specifically is that there was approximately, I think, 37 or 38 Medicare Advantage plans in New Hampshire, and I think that's like reduced to almost half. And so these people that were enrolled in the Medicare Advantage plans all year long, now that they're in open enrollment, they're being forced. Many times you just stay on your same plan. They're being forced to make a different decision. So the people at home, they really do need to figure out a way to look at what they're going to transition into and what's best for them. Our residents at our nursing home in particular, I'm just going to say it out loud, just going to a normal Medicare is really the way to go, because unfortunately you can be a resident in our facility, you can have maybe a fall or something that happens that causes you to then need to access your skilled benefit, because you end up going out to the hospital and you come back and need to get some skilled rehab, and you may find that that Medicare Advantage plan that you enrolled in that we're not in contract with the company, and that doesn't cover your skilled needs. Traditional Medicare always does, but that's where we get caught in a catch-22, is that you may want to choose us. You may live out in the community and want to choose Maplewood Nursing Home as your place to come to get your skilled benefit to return home, but you may find that when we do an evaluation of your insurance, that we can't admit you because your insurance will not cover your stay at Maplewood. So I mean, it's one of those tough situations.
Right. And again, if people are listening out there, we at times do get in the weeds here, and if you have a question, if there's something not clear, then we just please ask. But where I want to veer to now more is, we have the big beautiful bill, and there's some things that came out of it. The first one I'm looking at is work requirements. Does that affect? I'm guessing at the nursing home, it on some levels it may work. It may affect the workforce, but it could affect like EMS services, because if somebody can't work but they're under that list where they need to find work for whatever reason, then they lose Medicaid, and then we pick them up. That is there's no billing that can go on with that.
Yeah, well,
am I correct? Am I thinking?
Yeah, we're going to bill, but the likelihood that person's going to be able to pay the bill if they've lost their Medicaid coverage is they're not going to be able to pay it.
Yeah.
I mean, they're not going to be able to pay an ambulance bill if they previously had Medicaid and now they no longer have it because they lost it because they were not able to meet the work requirement restrictions.
For whatever reason. And my point isn't whether it's right or wrong, the work requirement. My point is there's a ripple effect to it.
Yeah.
And that at the end of the day, that affects us as a whole.
Yeah.
So,
and there is an expectation that there is going to be a huge amount of people that will lose their benefits, because when Medicaid expansion went into play, I feel like I shouldn't even quote the number, but it was a significant increase to the number of uninsured to finally being insured. So if we go back to those numbers, there's going to be a lot of people that no longer have insurance that have
well,
today.
it says here mandatory December 31st, 2026. Requires 80 hours a month of work, education, or community service. Exemptions are narrow and apply only to caregivers of disabled dependents or children. No requirement for automatic exemptions for veterans, individuals with disabilities, or those with complex conditions. So that's a good thing, right? Because they are exempted. There's no requirement for them to get a waiver for that, is what that says, right? Okay. Just want to make sure I had it right.
That's how I understand it.
Okay, that's good. And again, we're pointing things out here today because it affects us, and if it affects us, then the pass on is unfortunately to the taxpayer. So the next one would be more frequent eligibility checks. Medicaid eligibility redetermination will occur every 6 months, usually happen yearly, applies to adults in Medicaid expansion population. So does that mean that we're going to have to do it at the nursing home, or is it just those that fall under expand? And explain what Medicaid expansion is, because I didn't understand it.
Well, let me just answer that we're not anticipating needing more redeterminations at the nursing home specifically, but later I'd like to just expand on that, because we do expect some trickle-down effects that would impact our payments because of the additional eligibility requirements. But as to Medicaid expansion, I would defer to you.
So Medicaid expansion, basically, I am trying to remember what year, I want to say like 2011, there was the ability to expand the population that was eligible for Medicaid. Previously, Medicaid was very specific to like elderly, adult, people with disabilities and whatnot. There was a very specific population that could get Medicaid. The Medicaid expansion provided more people, adults that may have disabilities, may have mental health, may have substance abuse issues and whatnot to be eligible. Again, it has everything to do with your income level to become eligible, but it expanded the population of people that became eligible, which is what I was just explaining, that there was a significant growth in the number of uninsured, or a decrease in the number of insured to people then becoming uninsured under the Medicaid expansion program, which we have some programs, as I mentioned, that we know if they end up getting kicked off Medicaid because of one of two things, whether they don't follow through with the work requirements, which, some of these people in these predicaments, it's gonna be difficult. They may look normal, or that they should be able to be out there getting jobs, but there are other things that they're dealing with that does not allow them to be able to get to that level, to either whether or not be employed, for somebody to even want to employ them, or be able to make that step to get work, to get a job. That is going to be an issue with potentially having a significant amount of people taken off of Medicaid coverage. Further, this twice a year redetermination, if you've never been through it, it's a lot of work, and that's going to be another area where either people are going to not realize they have to do it, or they don't follow through with it, because already what you have to do annually to show that you're still eligible is going to now cause for people to lose their Medicaid coverage, because we just know it's going to cause people to not follow through with that requirement. What Catherine's probably going to explain now is the trickle-down effect of this twice a year requirement that is not something our nursing home, but you can speak to this.
So I'm going to back up a little minute, because Medicaid application, just the very first time you have to go through to get your Medicaid, has become so complex that if it weren't for Cheryl's team and our social workers up at Maplewood, there are many families or individuals that just cannot get through that process. And the amount of hours between your team and my team that we commit to supporting folks to get through Medicaid has grown tremendously, really since the additional 5-year look back was instituted quite some number of years ago. That was probably in the early 2000s, actually. That's a really long time ago. But what's happening now is our residents go through Medicaid eligibility on a one-time-a-year basis.
Mm-hmm.
But the impact of the rest of the population having to go through it twice a year, there's no change in the current staffing at the Department of Health and Human Services. And I've been very fortunate to be part of the Healthcare Association, and I've got a seat at the table with the Department of Health and Human Services. We've been really working collaboratively for a couple of years, in particular focusing on that Medicaid application and trying to figure out how to make it work more smoothly. But just last week, in talking with folks from DHHS, they're going through a hiring freeze right now, and they only have 50 staff allocated to that, but yet 9 of those positions are open. 11 of the remaining of them are going through training, and that leaves a very small amount of people to manage 15,000 cases that they have to process every year, with 700 new applications each month. And now you add on top of it twice a year eligibility requirements. The impact we foresee absolutely happening is it will slow down DHHS even further through no fault of their own. They're in a hiring freeze. They can't do anything about that, and they already have the 50 allocated. I don't anticipate that number's going to increase. So for our residents, if we have redeterminations required and the process slows down further, plus for all the initial Medicaid applications that are happening, the impact to the nursing home, we anticipate we'll have a financial ramification. We did some calculations based on some early numbers that we figured it could be an additional loss of, about $168,000 in a year, based on some hypothetical numbers that Cheryl and I put together, just because of the big, beautiful bill. So even though it's not a direct impact, the indirect impact, we foresee it increasing our losses and therefore increasing and impacting our taxpayer base.
Right.
I mean, my staff has a meeting once a month with the Department of Health and Human Services to discuss our Medicaid pending list. And they're very, I mean, they either get 30 minutes or 45 minutes, and time's up. When time's up, you can't talk about new cases because, and the cases that they're talking about are months and months old. That much of what they say is we're only up to being able to look at cases that were filed in, I mean, we're now in October. They may only be looking at currently cases that people filed in July or August. They're that far behind because of just being overwhelmed with the resources that they have in order to be able to handle what they've got on their plate. So they're already very, very behind in even being able to look at new ones. If they have to now be looking at another sector twice a year, it is just going to put so much pressure on the resources
and
at the state level.
And that segues into the next one, and that is 90, you have somebody that comes into the nursing home. They're in the nursing home. Their eligibility is pending approval from the state. That may take up to 6 months to get that approval. In the meantime, I'm being nice. In the meantime, you are paying for that person full cost, and in the past, you were able to go back and recoup or retro funding for 90 days. That's now been cut down to 60 days, or a cut of 30 days. So that's 30 days loss of revenue of when you're in reality already losing 3 months. You're not going to get paid for no matter what. Is that correct?
So the way it works is that when a person applies for Medicaid, you have the ability to check off on the application if you need the application to go back 90 days. When you put your application in for Medicaid, the initial interview is not where the problem is. You typically get a call shortly thereafter and says, okay, you need to now gather this laundry list of everything together, which is incredibly, there's so much, it's a lot. And when that interview takes place and they give you that list, you have 10 days to return the information to Medicaid, to this Department of Health and Human Services. If you did all of that, and that's wonderful, you still probably won't hear back from the Department of Health and Human Services that they've even looked at it for at least 45 days, if not longer. This is where it comes into their resources being overloaded. If you don't get your information in within 10 days, what they do is they send you out a letter, and it's all automatic, that you failed to provide. And that initial failure to provide, there is a grace period to the point that they will officially close your case. Between potential cases getting closed and some of the times that the failure is to provide is that the people are having a difficult time getting paperwork for their loved ones because they don't have the proper authority to go to a bank to get some things, or life insurance policies are a bear. They don't want to cash out life insurance policies. Sometimes it's just their inability to be able to get this information. So many times when a person is working through this process, their case gets closed because of failure to provide, because you don't meet those time limits, or potentially by the time Department of Health and Human Services reviews your case, they may find a period of time that you're trying to apply that they said you were over resources, even though you may have $10 more than what you're allowed, but if you're over resources. So when you get to that point where you finally hear back from them and they deny your case, that's where you have to start all over. And typically you used to be able to then ask for another 90-day retro, which would save us because we need that ability to start over. And now that made that time frame shorter. Originally it was going to be 30 days, and now it's 60. This is just playing with our ability to restart the game over and hopefully protect the date that we need from the day that we started providing care.
One last thing, I know we're short on time, but one last question I have is, where do people turn to get questions answered in this day and age? Whether they're part of the, looking at the nursing home or I'm guessing you would have social services that may be able to help them on some levels, but if you're not, and you're just somebody out there trying to figure it all out, because it's complicated, and listen to this, everyone, there's a lot of scams out there. And there's a lot, and people are getting barraged right now. I've talked to 2 or 3 different people that all have said the same thing, that in the last 3 to 5 days, there have been a multitude of people calling them about plans that they could step onto or take on. And be very careful of that. But where do people get guidance, real guidance in this day and age? Do you know?
Well, theoretically, New Hampshire Easy, a state level platform website, is supposed to give you some support. I do find it a little challenging to navigate myself. And there is still the
Service link.
service link, thank you.
But they've actually,
They
they're
stopped
at their
taking people
capacity.
locally right now. They're at
Yeah.
capacity. So
Yeah.
so
Maybe this is the next podcast. I
Yeah.
wonder if we could get somebody in from
we
one
will.
of these agencies before open enrollment closes to give some good key guidance for people of what to do.
I think what I might do, I know there's an individual in Dublin that does a lot of this work. So I might reach out to them and some other people to see what we can do and educate ourselves and go from there.
Yeah.
Maybe.
I mean, we do have it's kind of like going to your accountant. There's guidance I can give to our staff and whatnot, but when it comes to like filling out their W-4s and stuff like that, but I always have to preface that, you can't count on that everything I'm giving is, is 100%. So certainly I feel like if there is support we could do at this level at the county government, we could give some good direction. So I'm not trying to open up our, because we do have a lot to do here, but I suppose, I can give out my email address that if there is something we could try to help in a certain level.
Yeah. It's just something I've been thinking about. How do people get these answers? So I want to thank, I know it was a quick 40 minutes, but it was hopefully beneficial for those listening in, and hopefully it was beneficial for those that will be looking online to either, you can get us on County Conversations on Spotify, on YouTube, on our website, and on our Facebook page. And I believe MyKey Now also has a link for us there too. So thank you very much. Again, Cheryl Trombley, Director of Finance for the Cheshire County, and Catherine Kendall, who is the Nursing Home Administrator for Maplewood. Thank you very much for joining me today.
Thank you.
We'll be back in the near future with another episode of County Conversation. Again, I'm Chris Coates. Have a great day.